Hello, everybody. This is Billy Keck. I'm with Avanos Medical. I hope you can hear me and see my screen. I wanted to first off welcome everyone to tonight's session and thank the American Medical Society of Sports Medicine for providing us the opportunity to be here with you tonight. We're going to be discussing COOLIEF, cooled radiofrequency, ultrasound-guided technique to treat osteoarthritic knee pain. My name is Billy Keck, and I'm the Associate Director of Global Clinical Affairs at Avanos Medical, and I'm humbled to be here with you this evening. I'll be hosting the presentation tonight, and I'm joined by our featured speaker, Dr. Chad Stevens. Dr. Stevens is the President and Managing Partner of Noble Pain Management and Sports Medicine in Southlake, Texas. So tonight, as I mentioned, we will be talking about COOLIEF, cooled radiofrequency, and go through ultrasound-guided technique for genicular radiofrequency ablation to treat osteoarthritic knee pain. So the disclaimer is this information is for educational purposes only. Always use your independent medical judgment and discretion when using any of our products. This is not intended as a recommendation for use for Avanos products, and we are sponsoring as Avanos Medical this presentation. There are inherent risks with all medical devices, so please make sure that you review the COOLIEF the instructions for use prior to utilizing this product. Again, this is I am Billy Keck, and Dr. Chad Stevens is also here as well. So I'm going to go through a quick background of what cooled radiofrequency ablation is, just to ground everybody. This is the equipment. This in the center here is the generator that we have, and on top of the generator you will see some pump heads. Those are utilized for the water pump. You also have radiofrequency probes on the bottom right of your screen, and those are used to address the nerves that are transmitting pain. Additionally, there's a grounding pad that's this blue area kind of here in the middle that this is also required to do radiofrequency ablation procedures. So for what is radiofrequency ablation? So basically what we're trying to do, the goal is to disrupt pain signals that are being transmitted by nerves. Okay, you can do this several different ways. You can use chemicals, you can do this physically with a knife, or you can use radiofrequency ablation, use temperature to help destroy or interrupt this nerve's ability to transmit those signals. Okay, so what we're going to talk about tonight is radiofrequency ablation, which uses a process called ionic heating to ablate nerves. And there are several different radiofrequency products out there, but they're basically classified into two different classifications. So standard radiofrequency ablation and then also cooled radiofrequency ablation. So what is ionic heating? Okay, so basically radiofrequency energy causes oscillations of ions within the tissues. And the resulting friction of that creates heat. And so then heat, you generate enough heat, then you can create temperatures in excess of 80 degrees Celsius, which is what is utilized to ablate the nerves. Okay, and so we call this area that has this heat as lesions. What's important to know is that lesioning actually begins at 43 degrees Celsius, but the target temperatures that are commonly utilized in clinical practice exceed 80 degrees. Okay, so standard radiofrequency has been around for many years. There are some limitations to the technology. A lot of what happens is the energy is coming out of this tip of this needle that's placed hopefully parallel to the nerve, as you can see in the image here. But what happens is as the energy comes out and exits, the tissue that is touching and adjacent to that probe tip, that metal gets charred. And what that charring does is it creates an insulative barrier, which prevents energy from getting deep into the tissues. Okay, so what you end up with is a smaller lesion that's basically limited to the shape of the active tip of the probe that you're using. So you have an elliptical shaped lesion, and so what this means is you have to be very precise with your placements, and it also the physics or the body cannot deal with the way the body deals with the amount of energy being put in. It basically creates a stunted lesion. Okay, so that's what's been going on all this time. And with cooled radiofrequency ablation, what we've done is we've internally circulated water through the probe tip. Okay, and so by doing so, we're maintaining the temperatures at that probe tip to 60 degrees. Okay, and so what what that does is it prevents that charring effect from happening. Okay, so the char doesn't get built up where the tissue meets that probe tip. And so therefore more energy can be pushed into the system. It can be pushed deeper into the system, and you get a whole different shaped lesion. You get a much larger size. You get a spherical lesion. You get distal projection beyond the end of the tip. So it's a much more forgiving technology, and as well, it also increases the amount of energy that gets put into the system, which can actually do a little bit different type of damage to the nerves. Okay, so that's what this is. So that the tissue, what's important to note is that the metal, while the metal stays 60 degrees, the tissues around the tip get up to and exceed 80 degrees. Okay, and so this is what I was talking about here. You can see that the shape of the lesion is vastly different from between standard RF on the left and cooled radiofrequency on the right, including lesion size, this distal projection, which helps you with bony landmarks, especially like in the SI joint and other areas of the anatomy where those nerves can hide. This allows you greater flexibility in your placement and also more opportunity to hit the nerves that you're targeting. Okay, another thing to note is that COOLIEF is the only FDA cleared device that's allowed to be, that is indicated for the treatment of pain associated with osteoarthritis of the knee. Okay, so some of the trials that we've done, we presented to the FDA, and they looked at the data, they looked at the actual data, the analysis, the stats, all of the information, and basically gave us this indication to allow us to target specifically patients who have osteoarthritic knee pain with this product. So beyond that, there's a lot of literature to support the use of the product. As you can see here, we've got over 70 publications, peer-reviewed publications in the literature that discuss COOLIEF products. You can see the majority of those are in the knee, which really basically started after about 2014. So there's been a tremendous amount of activity and a tremendous amount of work done in a very short amount of time. You can see that we've got other publications and other indications up and down the spine, as well as hip and shoulder. So another item here to mention related to that is, not only do we have a large number of publications, we have some very high quality publications. So we have 7 level 1 randomized controlled clinical trials supporting our products across multiple indications. I've got 12 studies that indicate that 12 months of relief is absolutely possible, and 3 of which even indicate that 24 months is actually within realm of expectations. If you look at the top left, we do have 5 publications that indicate that 12 months is possible in the knee, in this indication that we're going to be talking about this evening. Okay, so just as a quick little sample here, this graph shows the results from 2 of our trials in terms of pain scores. So the NRS scores from 2 of the large multi-center clinical trials that we've run. The Davis studies, there's Davis series of papers, Davis, Hunter, discuss the 6, 12, and 24-month results where we compared cooled radiofrequency to intra-articular steroid use. And what you can see here in this green line is patients started out above 7, landed right about 3, and then basically stayed flat through the 12 months from there. And the important thing to note is that 65% of the patients at the 12-month time point here were still seeing greater than 50% relief from their baseline pain. Okay, if you look at the blue line, this comes from the Chen series of papers where we've got the Chen and Chen published. We have a 24-month coming as well. But basically it showed very, very consistent, very, very similar curve and similar results. And we actually saw 65.2% of patients in the Chen study versus 65.4 had 50% relief at that 12-month time point. So what we're seeing here is, 1 is consistency in data, 2, it's repeatability. We've got over 140 patients initially treated with cooled RF to provide this graph from 20 different centers across 2 different multi-center trials. Okay, so you've got durability, consistency, and repeatability here. If you compare that against the standard radiofrequency studies out in the publication, you can see that there's something going on here, right? There is a difference between the technologies. The standard radiofrequency technologies have a much more variable response. You have a very different curve. RF does work. It definitely works here, but what you're seeing is that pain return is very different than what's going on with cooled radiofrequency. And we believe that that has to do with the energy that's being put into the system. And remember, you know, that tissue charring that happens right at that tissue interface from the probe tip in the tissues in standard radiofrequency is not there in the cooled radiofrequency. And so not only do we get a larger lesion, but we also can pump in a lot more energy, which clearly is having some clinical effect, as you can see when you look across the different publications. Okay, so in terms of knee osteoarthritis, you know, this is the current, you guys are very familiar with this, the current treatment algorithm involves, you know, medications, and you start opioids, and then steroids, HA, and then there's kind of this gap before people become surgical candidates, you know, if they ever do, right? So patients spend a lot of time in this non-operative phase, about nine years, seems to be, I think, what the research has shown. And so there's kind of this big gap. And so we believe that that's what our literature and our publications and our research is showing us, that is the gap that we are here to fill. So you can see we're getting far bigger duration of response as well. And, you know, the other thing that we've got is we do have publications indicating that for that patient who has idiopathic post-total knee pain, everything looks good. There's no loosening, the hardware is in place, everything looks good, but they still have pain for some reason. Can't really give them an injection in their joint because they really don't have a joint anymore. So we have some publications that indicate that COOLIEF is a viable option for this group as well. Okay, so now I'm going to turn it over to Dr. Chad Stevens to get through the part you're interested in, the technique portion of this evening's presentation. So Dr. Stevens.
All right, thank you, Billy. Thank you, everybody, for getting on tonight. I hope you guys are going to really enjoy this. I want to give you just a little bit of feedback, or more like background about myself before we get started. But back in the day, you know, when I was in graduate school, I was also a vascular technician. So as a vascular technician, one of my jobs was to rule out DVT studies, arterial studies, lots of things throughout the hospital in San Antonio. And I became known as Doppler boy. So I tell you that just because I want you guys to feel like you have one leg up on me. But on the other hand, it's kind of like Superman. It's kind of my Superman name, except Doppler boy sounds a little bit lame. But what it was to me was a launch into the love of the use of ultrasound waves as diagnostic and treatment tools. And so I trained under a lady who was one of the best, who trained for Hewlett Packard and several other companies during her career, and she was at the pinnacle of her career. So I was really blessed. But what I want you to know is, if you see this poster behind me indicating my practice, logo, the machine I drove around was called an AccuSon, and it wasn't that much smaller than that. It was about 6 feet by 3 or 4 feet. And it had literally a driving wheel, and I would go up and down the elevators and go and isolate veins for the surgeons so they could get central lines and whatnot in. And so I became very aware of the benefits of ultrasound. We even did ultrasound of the circle of Willis in the head, and we did. I mapped out veins for the surgeon to go and do grafting for either bypass surgery, peripheral or cardiac. And so it's a really cool thing. But what I want to show you is this. This is my ultrasound machine. And this is the wand that goes along with this, which is my little Apple. These two things disconnected other than by Bluetooth comprise what makes my ultrasound unit. And so I hear a lot of people say, man, I'd love to get started, but I was pricing those things, they're like 25 grand or whatever. And there's some truth to that. If you want to get an office-based, big, high-end ultrasound, you're going to spend $20,000 or $25,000. But this one I just showed you is about $4,000. And if you're interested in knowing where to get it, I can direct you to the guy. I just saw him a couple weeks ago in San Diego. He not only has the units, but he also teaches ultrasound techniques, and he's one of the best. And so, not a physician, but an excellent clinician nonetheless. And so I want to start out by just telling you that my roots are pretty deep in this. I've been doing cooled RF since 2004 when I started my sports fellowship, and then through my pain fellowship we did it, and I've been doing it ever since. And so even just today, had several cases where we did this. And so I do believe in this product. I do believe in the outcomes. Billy and I have spoken multiple places before, and I've seen the studies he's presented. I usually get closer to 2 years with my patients. Relief than just 12 months as the studies are showing. But the fact of the matter is we need to start figuring out how to identify who these patients are for you so that you can see these people that are walking out of your office and make sure you identify them and get them treated and find yourself this niche of how to treat knee pain. Let's go to the next slide, please, Billy. So obviously disclaimer, some of the stuff Billy's already talked about, and this is important, but this is the slide that everybody can read on their own. But the fact is, everything we do has risk, and I want you to understand that I don't expect you to be able to watch this webinar and do an ultrasound. I was trying to rack my brain as to, I've taught a lot of people how to do ultrasound through the years. How do you teach somebody on a webinar how to do minute little changes, you know, with the wand in little different positions to stay in line or to work out of plane? Some of those things are things we just have to kind of learn as we go. But I do want you to know that ultrasound placement of these, either the needles for the genicular block or the COOLIEF actual probes is very easily taught, and I can show it to you tonight. And if you have a need for hands-on training, that's available as well. Next slide, please. So the IFU, and whenever you start to talk about what are we doing, first you got to figure out what are the indications, because we all want to try to practice both evidence-based medicine, and we also want to stay within the realm of what the product is produced for. And in this case, I'm just going to read part of this, but this is intended in conjunction with radiofrequency generator to create lesions in nervous tissue. So it obviously connects to the machine that Billy showed you, and it's new and improved and even more exciting than it was. But what it does is it uses a contrast medium, which is usually saline, to deliver anesthetic and heat to that level of tissue that you're concerned about. And in this case, when you're thinking about genicular indications, so genicular nerves of the knee, usually we're talking about people that have had problems for more than 6 months, people that have been treated conservatively, grade 2 to 4 osteoarthritis. But for the most part, this is really the key here. If you take them to do a genicular block and they don't get any benefit from it at all, they're not a candidate. Plain simple. You know, there's the only thing, unless you just don't have confidence that you place the needles appropriately, that is a person that's not going to benefit from this. Also, if the patient is coming to you saying, I've got instability problems and my pain is kind of bad too, then that's still not a person I would go after, because they need something to stabilize that joint, possibly an implant. But the ideal patients are the ones that have a stability factor of their knee that's solid, and they have pain, and they've gone through the things that Billy showed you, from steroids, which I hate, to HA, which I haven't used since maybe 10, 12 years ago. You know, we inject everything in the knee. I mean, just a couple weeks ago, I injected my own knee before we went on our trip. I mean, we do these things to buy time, but what can we do to help with the pain that's going to be more long-term, and also that could potentially prepare somebody for going and having a TKA at some point, getting that knee replaced. And we have studies underway, and some that have already resulted, where post-operative pain control was better after the use of a cooled radiofrequency genicular procedure. Next slide. So some of the advantages we're going to talk about today using ultrasound, but really and truly what I want you to get from this is that patient selection consideration. So the way you should look at that is everybody you saw today is probably a candidate for some sort of COOLIEF procedure, but who came into the office limping? Who came in the office on a cane? Who came in with a walker? Who came in talking about instability of their knee? Maybe they're there for hip pain, but you notice that their knee is a problem. And so as we know, adjacent joints can be a problem. So I'm going to show you some advantages of ultrasound. I'm going to talk about patient considerations. Then we're going to show you a little bit of the technique. Billy's already given you kind of the nuts and bolts about how this thing works, you know, from a standpoint of physics. But what I want to do is just show you how do you technically perform this, because I want you to see how easy this is. And then we'll talk about some pearls. I think when you have these meetings, if you just walk away, if you've already done these things and you walk away with 1 or 2 little pearls, it was still worth your hour. Also, we're going to talk about things to watch out for, those precautions, and we'll just kind of summarize. And then I think we'll have a little bit of a question and answer session. Next slide. So when we talk about the considerations, we already described this, but for me, there's a couple of people that are not on this list, and that is those people that have knee pain, that maybe they've already had a couple of knee scopes and the doctor says, hey, you know, the articular cartilage looks pretty good, the meniscus is not a problem, but they're still having pain in their knee. And I think those young people are a good candidate for this procedure. It doesn't have to always be, you know, extreme osteoarthritis for me to reach for this. There's people that have had knee replacement surgery and they still have, even though they have a Picasso in place, I don't know if there's any orthopedists in this call, but you've made this beautiful picture, but the patient says, my pain's no different. Then what are you going to do? Well, one of the things you do is you send them to somebody like us, because then we have a chance to go after them post-operatively and still try to help them with their pain. You're going to hear from one of my colleagues in Australia, Greg Harvey. And Greg Harvey just did his 400th COOLIEF RF of the knees. And that's a orthopedic surgeon in Hobart, Australia, of all places, or I guess it'd be Tasmania. I get that confused all the time, even though I've been there. It's beautiful, amazing place. But what Greg has found, he did a knee replacement on one knee. This is a little study of one, but on that knee replaced knee, he had some decent outcomes and did okay like that. But then it came time to replace his other knee, and Greg's not much older than I am. But what he decided to do was go for the COOLIEF, and his partner Paul Harvey, with no relation, spelled differently on the Harvey, he had him do the ablation for him, and he's doing great to this day. So he's not only a hook, line, and sinker believer and a product of the company's outcomes, but he's done a ton of these. Again, he's an orthopedic surgeon who's done over 400 of these. I taught him how to do this maybe a year and a half ago. I may be off on my COVID dates, but it may have been 2 years. But a lot of cases in a short amount of time. Next slide. Oh, there was a little section there about genicular blocks. Don't go and just flood that with a ton of local, because what will happen is you'll get some false positives. So what I tell people is use about a half cc of 0.5% Marcaine. And what you're looking for is immediate response, at least 50%. Your state may have a different requirement. It could be even up to 80 or 90%, but a short-term benefit. And don't tell your patients exactly what to expect. Just tell them, I'm not going to tell you exactly what the game plan is, but I just need you to write down every hour today what your pain relief is, what's your pain level. And then each day thereafter, I need you to give me what your pain level is, 0 to 10. And then when they bring that in, you look it over and you make sense of it for them and say, you're a candidate or you're not a candidate. And I can't stress enough that sometimes these patients are going to come in, and this is going to freak you out a little bit, but they're going to come in and they're going to talk about how they are feeling well and you did a great job. The procedure healed them and all you did was a genicular block. So they may feel better for a few weeks. If you bring them back in 2 weeks, they may still be feeling better. And then you have to tell them, well, sir or ma'am, I'm glad you're better, but that wasn't the procedure. That was just the genicular block, the diagnostic test, if you will. And then once they understand that, I just say, hey, call me when your pain comes back, because it will. So let's go to the next slide. So that moves us to the next section. Benefits of doing ultrasound, I think, are pretty obvious, but let's state a few of these. Number one, you don't have to worry about radiation exposure. If you're like me, I wear lead all day long. I had a full OR day case load that started at 6 a.m. and finished about 5 minutes before this webinar, honestly. I just literally drug in this just a minute ago for my last case, but I'm on cloud 9 because my last patient had foot drop, and after doing a fusion on her spine, she no longer has foot drop. So I just got those texts and I'm super excited. And I got a lot of radiation today is what I'm trying to tell you. And even though I monitor it, we have these little monitors and we are careful about our exposure. And as doctors, we need to be very serious about that. If you've been watching our med combines that we do, you'll hear about control rad, an option to put an attachment to your C-arm to reduce your radiation by like 75%, which is substantial. But still, what else can you do to reduce your radiation? Use a device that doesn't require radiation and gives you the same result. So that's one thing that's about ultrasound that's awesome. When you do this with real-time guidance, you can actually see where the needle's going. So I can't stress to you enough that it is not a comfortable situation, even to do a nerve block on a knee. When you are docking on the bone and moving around and scraping around the os, they're going to be a little uncomfortable, and they may even scream some explicatives, especially if they have Tourette's or something. But they may scream some things you didn't really want to hear them scream. It's not comfortable. But when you see the ultrasound guided treatment today, what you'll notice is that by coming in at an angle, you can come in right in that neurovascular bundle and you can completely miss the bone itself while still getting a good block or ablation. I think that's why this is better in the office than fluoro-guided. Honestly speaking, we put stimulators, we do kyphos, we do everything in the office, but I really think it's difficult to do a genicular block using fluoro in the office if you're going to hit the bone. So is it available everywhere? Most anywhere you're in a hospital that has anesthesia services in the pre-op area, they're going to have an ultrasound machine. It's getting to be commonplace to do, not just going and doing general anesthesia anymore, but regional anesthesia. And with regional anesthesia, there's a lot of ultrasound guided blocks. And so every facility I work in has their own, but as I told you, this little guy goes everywhere I go. Literally, when I'm covering a football game, I bring it with me to look at a fracture or other things like that. I mean, this little guy has done a lot of good things for me. Plus, I use it on multiple procedures, and I use it to show patients their anatomy. I saw a patient yesterday that had hamstring tendinopathy on an MRI, and she's like, I just don't see it on the MRI. And I pulled up the ultrasound, showed her the ischial tuberosity, showed her hamstring, showed her the black hypoechoic area right by the attachment of the hamstring. And she went, oh my gosh, there's really something wrong there. And we're going to go and explore that with a treatment soon. It is very helpful. The cost is low to you. You can see these soft tissues very well. That's one of the benefits of ultrasound. You can see fluid, so you can see effusions. So when you're looking at a knee, you don't have to guess. You can see the fluid. And then you got the old, I don't know what you would call it. I guess my vascular days, every once in a while, yes, I turn on the Doppler because I like to see those blood vessels. And even sometimes I catch myself like going, oh, that's kind of a cool popliteal artery. And I just kind of follow it up and down and go, oh, little atherosclerosis. I'll tell them about that later, but there are abilities to do Doppler. Why is that important? Well, a couple places, especially when we start talking about the application of the hip, you're going to be medial and lateral to the femoral artery. And there's everywhere I teach. I just got back from Hawaii teaching this weekend. And even then, the doctor was saying, I think I'll do my first several cases with an ultrasound map of the femoral artery. And I don't think it's necessary unless you just can't palpate it. But let's say you can't palpate it. And when I was teaching in Australia last year, the very first patient I was proctoring had a leg the size of Texas. And we did our very best to palpate the femoral artery, and there was no palpating. So we marked out for the surgeon and pain doctor that were doing it. And then with the ultrasound, we were able to show them what to avoid. And we had a nice, safe hip procedure. Next slide. And so how do you place the knee? So I do this the same whether I'm doing a trial, when I'm doing in the office, whether I'm doing the OR, whether I'm doing a genicular block or an RFA, ultrasound or not ultrasound, using fluoro. So I think that the easiest way to do it is just to put the knee in a little bit of flexion. And this knee is kind of pointing a little bit not north. I like my knees to point exactly due north until I figure out if I'm doing ultrasound, okay, am I going to just ultrasound the inferior medial or the superior medial or what I'm going to do? And then if I'm going to do that, I would put them in this position here. So with fluoro, always due north. With this, you want to get them into a position where they have a little bit of a flexion in their knee, and then decide which approach you're going to use. And in a minute, I'll show you some pictures where you can easily see the approach we use. But this is probably a little overkill for what we're doing, just a genicular block. I think I would just use sterile towels and do it in the office. If I was in the OR, obviously you can see a probe here. So this is going on for the further ablation. So I would use a full towel set followed by either drape or at least a 3/4 sheet so that we can take the wires and attach them to the machinery and not break sterility. Next page. So this is what it looks like. Okay. This is where you have to understand a little bit of the ultrasound probe, and this is not rocket science. Okay. But every probe, do you guys see this notch right here? Every probe has a notch, okay? You can call that what you want to. It's been called the Chad before, and I appreciate that because I haven't done many things to put my name on, but this notch, we call that the Chad, or any notch. And so what happens is when you come in to approach this, you can see on the top picture, you come in with the notch north, and you come in plane. So when you're talking about in plane with anything, it's going to be a longitudinal approach with the tissue that you're approaching, right? So when you come into this picture here for the medial genicular, what you're going to see is you're going to see the femur and you're going to see the meniscus, but most importantly, you're going to see this blue dot up in the up left-hand corner. So if you have this in the proper orientation, it's going to be in the upper left-hand corner. And why is that important? Because that's where your needle is going to enter in, and I'm going to show you that in a minute. But then what you do, so now we've gone exactly longitudinal. Then what we're going to do is we're going to walk this up to the point where we have the shaft of the femur meeting the diaphysis there. And so when you start to get to that condyle, where that middle point is with the arrow, show us the arrow there, Billy. There it is. When you get to that point, what you do, next slide, is you rotate your transducer this way. So now if this is the middle aspect of the knee, your notch is medial. And then you'll see the vastus medialis, obliquus muscle. You'll see the neurovascular bundle here. And so that's where we're starting to identify the structures of the vascular bundle. And so you can, again, put on your Doppler or whatever you want to. I think so at this point, I don't think it's flipped yet. So go to the next slide. So now what we've done is we make a mark and we flip it. And when you flip it, what you're going to see is the femur is going to be this hyperechoic. So the basics of ultrasound are you call a bright white hyperechoic and a dark black hypoechoic. And then what you're looking for is the structures that you want to innervate or you want to put the needle into. And you can see at the top of this dome, it says neurovascular bundle, and you see your blue dot in the upper left-hand corner. That is where your needle's going to start. And so you can see the mark over here. So what we've done is we've gone from exactly longitudinal to transverse with the notch going towards the patella, right? And then just to the side of this device, which will be whatever probe size you use, then you drive this in and you'll see it come from the upper blue straight towards the neurovascular bundle. Thank you, Billy. So that's how simple it is. And so once again, you can see where the bone is and you can see how you want to miss it. And what you want to do is actually slide the needle in. I think the next slide shows that, right into that neurovascular bundle. And what I want to really stress to you is you can see the trajectory of this needle. It's not going to hit the bone at any point unless you just make a direct change, and you're going to be exactly where you need to be to do either the block or the ablation. The patient won't feel anything after you puncture their skin because you're not touching anything but soft tissue. So you advance this is talking about the ablation now. You advance the 17 gauge introducer and you're using this approach until you get to about the 50% or 50 yard line of the femur. And that is the point where you would be on when you're doing fluoroscopy, you always want to make sure on your lateral that you're somewhere between 50 to 70% posterior on either the femur or the tibia, whichever bone you're working on. And that way, when you put the probe in, the actual, the way Billy showed you this, there's an actual indicator that's more proximal than the tip of the probe. And you want that to be right at the 50 yard line there. So that'll make sure you're posterior enough. It'll make sure you are right at the juncture of the diaphysis with the shaft. And you can do the ablation there just like any other ablation where you ramp up the machine, do your motor testing. You do up to 2 hertz there to confirm there's no motor activity. And usually there won't be, but go ahead and do it. And then when there's no motor response elicited, you turn the machine to 60 degrees centigrade and you burn for 2.5 minutes. Next slide. So superior lateral. So you're going to start to see rinse and repeat here, but the structures are a little different, but the bones are not. So that's what I want to stress to you. So again, you're going to come in on the superior lateral. You're going to come in with the longitudinal, with the notch forward, and you can see that in the bottom picture. You move the wand, and when you're moving a wand, you don't need to be doing a lot of this action. Once you get on there pretty well, it's pretty much just a little bit of hand back and forth and just movement up and down, north and south, until you get the picture you want to see, where you see the bottom picture, you're starting to see the shaft of the femur, and you have that blue dot that tells you where you'll be coming in. So the next slide. Once again, you want to slide to the point where you see that neurovascular bundle in the longitudinal, and that confirms where you want your goal to be. What I tell people, and I just taught this just a couple days ago in Hawaii, what I tell people is once they get that neurovascular bundle in the middle of their ultrasound screen, that's the time to turn to perpendicular so that you'll see your next view to look like this. And you have different muscles involved, but again, the bone structure is the same. So go next slide. So then when you get to this picture, and again, you're going to have the notch facing the patella and you come in just on the inside of the probe, it will walk you from the blue dot down to the neurovascular bundle, which you can see once again. And next slide shows you how that looks. The only difference being the IT band is there, right, into the vastus medialis. And you can see that you're walking up about halfway. You see this line that's there. It's not on every ultrasound machine. That's just on our slide. But if you take it to the 50% mark, kind of the dome of the condyles, what I tell people, then you're going to be in a good place. It's also an awesome way to visualize the IT band for IT band friction syndrome, bursitis, etc., especially the distal IT band in distance runners. So RFA, it has a lot of different indications. In this case, I think you'd keep the same indications with OA, post-op knee, multiple scopes without the benefit of what they're looking for. And maybe even the fact that a surgeon says, I've done all I can do to this patient, they still have pain. I'm going to get a little personal. I mentioned that I'd done an injection on myself. Honestly speaking, I would have done an RF on myself the day before we left for our vacation. This was 2 weeks ago now, but I would have done it if I had pain. But I don't have a lot of pain. I have instability. When I take a step, I was a multiple sport athlete. When I take a step, sometimes my knee just buckles on me. And if you don't know what tricking a knee out or buckling feels like, your patients will know, especially athletes will know. And again, I don't think this is the best treatment for somebody who has minimal pain but has tricking out or instability of the knee. But for the flip side, where somebody's got a lot of pain and they're a stable knee, I don't think there's anything better you can do. Next slide. This is just going to take you through the superior lateral. What you want to remember, just keep going. What you want to remember here is, and we've kind of shown the same thing here with the only difference being you're looking at the tibial epicondyle before you flip to the next slide, which will show you, again, your cross section there. What I want you to be aware of is the tibial is very similar to any other level you're doing. You want to always avoid the inferior lateral portion of the knee. Obviously, there's a common peroneal nerve there, and it can lead to foot drop. And in contradistinction to recovering somebody from a foot drop like we just did tonight with our fusion, which was so exciting, you don't want to be the one that gives somebody a foot drop and then they love you for different ways and call different people that will love you at the stand and you'll have to defend yourself. And so there's really no excuse for putting it inferior laterally. If you think somebody has those conditions, such as peroneal tendinopathy, peroneal pain, those are the things you want to try different applications for. Next slide. So this is, again, what we're looking for. And you can see the needle coming in a nice angle. I can't stress to you enough. If you can find the blue dot and you can find the notch, you can do any of these levels that we've just described. And the same story, same amount of time you burn. You also want to make sure the needle's in a nice horizontal, which you can see here. When you see that blue dot, you're going to think, well, that's where the skin is where we enter. But in reality, it is going to be a little bit more horizontal than that dot would take you. But if you come in at that dot and you're coming straight at the knee, what I would encourage you to do is just come a little bit more horizontal and just go for the dome of the tibia. Next slide. Same thing. So next slide. The difference here, you have the little bit of an issue with the fat pad there. When you're looking at tissue, I'll just go into this real quickly on this slide. I think you guys know this, but muscle that's striated is going to have kind of this linear white approach. It looks striated, like you would think of as a striated muscle. You would think about a tendon that's strong. And so any healthy looking muscle looks like that. Any healthy looking tendon looks like that. But if you look at the far right portion of that screen, just where Billy's arrow is, that black hole there indicates there's something not right with that tissue. And in this case, it might be something as simple as not having complete contact. When you have your jelly here, and I brought some sterile jelly here in case you don't know what that looks like, but sterile jelly, apply to this. If part of your transducer is not in contact with the skin, you'll get this false hypoechoic area. But if your whole transducer is well lubricated and it's all in contact with skin, this is something pathologic with the tissue there. Next slide. So again, you're able to accomplish all of these approaches superior medial, suprapatellar. Oh, suprapatellar is a little bit different because what you're doing there is when you get the femur into that transverse appearance, you can see the quadricep tendon. And we always have this discussion about on the quadricep tendon, is it better to come in like this from a transverse kind of horizontal approach, or is it better to drop down, directly from anterior to posterior like we do with the when we're doing the fluoroscopic guided? I personally think that this is better because, again, you can stay off of that femur and provide your patient an adequate block or ablation without too much discomfort. Next slide. So the diagnostic blocks, again, we're going to use a really small amount of local. You're going to exactly go the same location. And people say to me all the time, prove it. And I'm like, well, what do you mean prove it? And they're like, show me that this ultrasound goes to the exact same place as the fluoro. And so for the first few times, if you have both in your hands, go practice this. And what you'll notice is if you turn your notch the right direction and turn the transducer the right direction at the exact right spot I showed you where that neurovascular bundle is, you will land directly in place. In fact, maybe even a little bit better. Why is that? Because sometimes when people are using fluoroscopy, they come in at a little bit of an oblique angle and they hit the bone. And when they hit the os and they get to the lateral, they realize they're not posterior enough. So what they have to do is change their angle to pass forward. And what you'll notice is with this ultrasound guided technique, you don't have that happen at all because you can see the bone the whole time as you're driving it. And even though it's live, you're not radiating the whole room, right? So makes you more popular with some of the nurses, especially those that might be in the room with double lead because they're pregnant or something. Next slide. So this is a picture of a patient that's already had a total knee replacement. I mentioned this a minute ago that these were great examples. So when you do this, you need to be aware of where that implant is. So this is Rob Menzies actually, and Jeff Hawkins. These are two guys that I trained in Fort Worth actually, and two excellent doctors, both sports medicine trained. And they do an awful lot of ultrasound and they do an awful lot of fluoroscopy. In fact, Rob Menzies has his name on several of those papers that Billy presented earlier. And I've known Rob since he was actually a medical student and I recruited him to residency. So love the guy. But I think you need to be a little bit careful with that. And what you can see is with ultrasound, you can see on the lateral exactly where the stem is. On fluoroscopy, you usually can to some extent, but what will happen is sometimes you'll get your probe behind the stem and you won't be able to make any other picture despite the efforts of your rad tech to show you exactly where your needle tip is. And like I stressed a minute ago, you want to be, so if I'm looking at this the way I think I am, the patella is the top left portion of the picture. So what we want to be is anterior to posterior, probably just almost to the end of that prosthesis and be able to almost see the tip so that the ablation happens in the right place, but that might be just a tad too far. And so I think ultrasound makes that a little bit more easy to do without the risk of maybe even going too far. And obviously you don't want to get behind that, the tibia there and be in the popliteal fossa. Next slide. So a couple pearls. So I already gave you the biggest pearl there is. Don't block that peroneal nerve because you may actually cause a foot drop. Motor testing, I think, is a must. And not only should you do this, but you should document you did it. Now, when you go to that inferior medial genicular location, there are occasions where we will actually go to do the ablation there. And if the patient is really thin, and especially if they have, just very small amount of soft tissue, sometimes you need to come in at a little different angle. And what I mean by that is, I think Billy stressed this, is the way these probes work in contradistinction to standard RF is these probes have a distal appearing lesion, and that lesion goes beyond the needle and it burns in all planes. And so what happens is if you come in directly perpendicular, great burn. If you come in almost completely flat, great burn. If you come in at some kind of obliquity, it's still great burn. So what I like about that is I know that I can put the needle in any way I need to, even with a little bit more angle, maybe from caudad to cephalad, so that I capture more tissue and keep the needle inside. So if you look at the probe and you can see silver from that indicator at the skin, then you're not deep enough in there. You might get a little scar. Now, let's just say worst case scenario, you get a little careless, they start playing AC/DC or something a little out of hand in the OR, and you aren't paying attention as the burn goes on and it backs up a little bit. What are you going to do? If you do create an eschar, it will usually just, I say usually like it happens all the time. It doesn't happen very often. But what I've seen in the fellows where this has happened is it just sloughs off kind of like a little scab after a couple of days. And you talk to the patients, how's your pain? I have no pain. Oh, that little dimple on my skin, no big deal. It's my knee. Who cares? Pain relief is amazing. So don't take that as a stress point where you go, I would do this, except that just sounds a little scary. Do it. Next is the pacemakers. We just always recommend that if somebody has a pacemaker or defibrillator, that you contact the representative and have them present if you want to. Blood thinners. So this is a thing, anywhere you can cause compressibility after you puncture somewhere, I think it's a little bit less concerning. Obviously, when you're doing hips and you're near a femoral artery, that's a big one. But that means very large in Texan language. But what you have is when you're doing these, I still take the same precautions during the ablation as I would for other procedures, keeping their INR under 1.4. When I'm doing a block, if somebody's on a medicine, it's more unsafe to take them off and put them back on and take them off, put them back on, than it is just to do the block with a 25 gauge needle. I'll just use a 25 gauge needle, do the ultrasound or the fluoro, and there's minimal risk. If you think about the anatomy, there's a couple of slides that we have, I think, in either in the end of this lecture, or we can get you to show the nerve anatomy of all the genicular variants, and it also shows some of the genicular arteries. But these genicular arteries are really small, and you're not going to have to cause, hold pressure and compress like you might the femoral artery if you punctured it. So just be cautious of your patient's blood thinners like you are in any procedure. And then number one mistake people make is they forget the grounding pad. So if you look at the machine, it says high impedance, you're like, it's perfect, everything's great, I can't do a better job. And they say, well, what else is there? Did anybody put a grounding pad on this person? Oh, it needs a grounding pad. So put a grounding pad on the patient, and you'll get a lot better activity with your machine. These machines are so smart, they don't let you do anything that would hurt the patient or that would not help the patient. So if you forget the grounding pad, it's just going to look at you and say, hey, what's going on here? Aren't you a smart doctor? And into your scrub tech smart, what's the problem? And then when you guys all throw your hands up, can't figure it out, and then you FaceTime your rep who's probably on the beach somewhere hanging out, they'll say, did anybody put a grounding pad on? You go, that's what we forgot. Next slide. So these pearls, you want to make sure that you get, as you're really targeting these areas, you want to know where the vessels are, where the nerve is, and where the bone is. And obviously the goal is to be in that bundle, but be in the nerve. And so some people go, well, if I'm doing an ultrasound guided procedure and the vessels are that close to the nerve, and it almost seems like they're on top of one another, and they kind of are, then aren't I going to burn the genicular artery? And the answer is maybe small little variants of it, or even remnants of it, or something you might, but nothing that's going to cause the patient any kind of vascular abnormality. Is there an artifact from the ultrasound? I think that when you think about that, lesioning doesn't really, it doesn't make it uninterpretable, but if you're kind of a little bit scared of what you're seeing anyway, and you think it looks like a boy or a girl, and you just go, I don't know what I'm really looking at, it just looks like a bunch of mess, it's going to cause a little bit of an artifactual change, kind of like what we're used to seeing when we see an MRI around metal. It's an unavoidable problem. But once you've placed the needles, if they're in the right place, you don't have to worry about that. Effusions, you can spot an effusion on this. And one place this is especially helpful is that the superior patella region, where somebody either has a previous implant or they just have an effusion that's collected in that bursa there. You'll be able to see that on the ultrasound, and you'll be able to go proximal to that. What about if you need to do an additional lesion? You can do that. I always tell people, burn at your liking, do what you feel like you need to do. But when it comes down to this, our lesion is about the size of a $50. And what we're doing is, after mapping out the genicular anatomy, we're using it to put it in the most proper place. And if you're looking at a fluoro, it's the confluence of the shaft and the condyle, and it becomes the same place when you're doing the ultrasound. And then remember, a small amount of block. I think the best thing to do, and there's a little bit of variation across the country what people do, but I think most of us are using the 4mm active tip. I mean, why not? You're not going to hit anything big, and you're not near any bad structures. So I use the biggest lesion type I can, which is the 4mm active tip. So you'll probably use a 50mm length probe with a 4mm active tip. Next slide. So in summary, this has been demonstrated through multiple studies, and Billy showed you those. I think you probably saw that little pie chart. Well, the majority of the pie, just like at Christmas time, the pumpkin pie is almost gone by the time I get to it. So I have to beat Uncle Darren to it. The majority of the pie was knee studies. This is what this company really started with, stresses, and there's great applications for shoulder, for hip, for all the axial skeleton, for SI joints, and it's wonderful. But when it really comes down to what they really hang their hat on and what their studies support, it's going to be their knee application. And what you'll notice is that other companies who say, oh, it's no different, just use our probe. Number one, I don't think you'll find that you get as good of a result and as long a lasting result. But number two, it's not FDA cleared for it in most situations. And number three, your lesion is going to be smaller, so you're going to have to do multiple burns to get the same benefit as you do with this one. And then again, there's strong evidence for this being a valuable treatment for up to 12 months for our patients. And again, I told you, my patients sometimes get up to a couple of years. Next slide. That's the end of my section there, Billy. So Billy or Stacy, have we gotten some questions that you'd like one of us to answer?
Yes, if thank you for that. If you have any questions, please type them in the chat. I guess at the minute, how long does this procedure take? And you currently do 4 burns on all patients, or yes, 3, or talk to us a little bit about that.
Yeah, so I mean, oftentimes, and this is what most people find out is somebody's pain anterior or subpatellar, they're always going to want to do the subpatellar plexus, that distal femur branch. But what I would tell you is on all my patients, I do that. There's really no reason not to. And in my younger years, which was probably pre-COVID, we've all aged a lot during the last year. I used to have dark, thick head of hair and no gray, and then COVID hit. And so when you think about back in those days, and I would have a patient come back in who didn't get anterior knee pain relief, but I'd already done the procedure, I felt a little bit foolish saying, well, why not just do that 4th ablation? And so on all my ablative treatments, I do that 4th ablation. And when you ask me how long, each of these ablations takes 2 minutes and 30 seconds, like we alluded to. And I would say, like the guys I taught in Hawaii this weekend, they were amazed, and gals, about how quickly the probes can be placed. We're talking about maybe it takes 20 or 30 seconds to get the probe appropriately placed and a motor test, and then just burn. So I guess, Billy, that puts a 4-level treatment in about the 10 to 15, 17-minute mark. Okay.
A couple of questions came in. Do you keep the ultrasound probe on during the 2.5-minute burn time?
So that's a great question. It depends if I hold it the whole time, right? So if you've ever done ultrasound, you know that after a while, it's hard to get your left hand to do what your right hand should be doing, and your brain to correspond to both those doing what they're supposed to do. So it gets a little tiresome. So typically, I find the nerve, I get my probe in the exact position, and I hold it the whole time. I don't really feel like I have to keep the ablation on the whole time. As we already alluded to, it just kind of makes a splash fire anyway. But if for some reason I feel like the patient moved, or I feel like I moved, we stop the machine and we go back and make sure we're placed accurately. But it's just like anything else. When you're doing a fluoro-guided one, once you place them, now some of these probes are a little top heavy, so you're probably going to, at least the inferior medial genicular, you're going to need to hold that the whole time. And maybe you need to hold all of them the whole time. There's no harm in doing that. I mean, whoever said that there's a problem with taking an extra little bit of caution? But especially if you think the patient jumped and moved because they felt something, or you think you jumped and moved because your hand slipped or something, reposition, turn the machine back on. But in reality, once you get the needle placed, hold it in place and you'll be fine.
Okay, thank you. What is recovery like? Can you talk a little bit about how long people are sore, if they are at all, a week, a month, a day?
So in general, I mean, I think it's about the same as whether you do fluoro-guided or ultrasound guided. I'm not sure I have any studies, I don't know if you do, Billy, to contradict the difference there. But essentially what I tell patients, and I just did several of these today, one on one of my reps from another company, actually it was cervical, but I usually tell people they may be achy and sore for a day to 2 weeks. And then by the 2-week mark, they come back to reevaluate it. And when they come back for the reevaluation, they may be starting to go from being sore to feeling better, or they might feel nothing at that point. And so I usually tell people over the first month, it's very touch and go. You may feel a lot of benefit or you may feel about the same. But I tell them if they get to the 3rd month and they're not feeling any different, that I'm getting a little concerned that the procedure didn't work well enough. And I have had people that almost 3 months to the day was when they came in and said, everything is so much better now. And so just be realistic with your patients. You don't tell them, okay, if I do this, you'll be in the wedding Saturday and you'll be able to dance with your bride, or you'll be able to dance with your daughter, or, you know, I mean, you got to be realistic, because any procedure, you want to always under promise and over deliver. That's just a good rule of thumb in medicine. And so this is a place where I really do that. And I think that if you tell them the worst case scenario and then it beats that they're going to be pleased. But if you tell them every one of my patients at a week is better, all the calls are going to start going ring, ring. I thought you said I'd be better in a week. I'm still miserable. You know, you're not like every other patient. Well, why am I not? You know, and pretty soon they question we did the procedure right or whatever. So give them the outside ranges and then beat the outside ranges.
Okay, thank you for that. We've got a couple more questions and only a couple more minutes, so I'm going to burn through and kind of condense some of these here. So we do have some studies that indicate that repeat procedures, patients who receive this as a repeat should have the same expected result as they did originally. So how often do you do repeats? Are there any limits? Anything we need to know there, Dr. Stevens?
So I haven't had to do a lot of repeats with ultrasound specifically, but I have several patients where I've done every 1.5 or 2 years, done the same thing over. One thing I will point out, I don't know if this is where the question's headed, but you don't need to redo those genicular proving blocks, at least in Texas. If I had an RF, it lasted 2 years, and I want to come back and do another one, I just go straight to the RF one more time. In fact, the person I did today had their RF by somebody in another state. We got the documentation of their improvement for a year. And when it wore off, it wasn't a COOLIEF, but when it wore off, I went in with the COOLIEF today without having to do genicular blocks.
Okay, awesome. Do you utilize steroids at the end of your lesions?
So that's another little topic that I kind of feel strongly about. I don't add steroids to any of the procedures I do. I know a lot of my colleagues do. I try to avoid steroids like the plague anytime I can. And as we know, there's a lot of ups and downs with steroids: heart racing, agitation, fidgetiness, facial flushing, even, you know, moon faces, all those things that we want to try to avoid. And I'm not saying one time doing it after the fact would cause that, but what's the real benefit from doing it? I just do local before and after each ablation with Marcaine and lidocaine mixed.
Okay, and your site of service, is it a surgical center, clinic?
So most of the time I do all my RFs at our surgical hospital, but I also do blocks in the office with ultrasound. And I also do blocks with fluoro in the surgery center. And occasionally, like today, I did 2 of the RFs in the surgery center. Just depends on the patient's insurance and the reimbursements and things like that that your local reps can go over with you.
Right, okay. I think one more question here. Procedurally, the inferior medial genicular nerve is deep to the distal MCL, with the lesion size of being circumferential from the tip without placement on os. Have you seen any injury to that deep MCL?
That's an interesting question. I've not been aware of anything in the literature, nor anecdotally from all the people I've taught that have had a problem with that. I mean, again, with the ultrasound, it's super duper easy to put the ultrasound right on top of the MCL and just walk it down to its attachment, and you can be 100% certain you're remote from it. But I've not had that happen. I've been doing this, I don't know, Billy, since 2004. I've done tons and tons and tons of these knees.
Right. Okay. Do you have any information about the ultrasound probe that you use?
Yeah. So the guy's name is Frank Finich, and I can get you his number real quick. This is called a Heel Sirion. There are other ones on the market, like a butterfly or some other things that some people use. Let me pull Frank's number for you. And this guy is awesome. If you just tell him that I sent you his way, it's 760-707-8531. Frank Finich, Finach. He's in San Diego. and I just saw him a couple weeks ago. He's alive and well and happy to educate.
Okay, so it looks like we're right at the top of the hour. So there's a couple other questions related to cost and reimbursement, and I wanted to let you know, reach out to your Avanos representative, because we have a dedicated reimbursement team to help answer those kind of questions, dealing with it with insurance and so on and so forth. And additionally, we do have cadaver workshops that Avanos puts on around the country over the course of the year, and we can actually set them up if you have a specific interest. So reach out to your Avanos representative as well, and we can get that taken care of. Dr. Stevens, any parting comments for our audience?
Yeah, no, I mean, really and truly, I think the best thing to do with any ultrasound application at all is get one and just put it on everybody who you love. I mean, I ultrasound all my kids, my wife, I love all of them, and I practiced on them. I mean, when I was learning to do ultrasound of the blood vessels, anybody who came through our house got an ultrasound put on them. But the key is you have to have the ultrasound available. And if you always have to go drag something across the office, you won't do it. But if you can just make a little buzz out to your nurse and say, hey, bring in my ultrasound, and 3 minutes later, or 2 minutes, 10 seconds later, it's in your hand, ready to go. And then you show the patient the anatomy and show them what's wrong. They're gonna be very impressed, number one, that you know your anatomy and ultrasound diagnostics, and then they're gonna be more apt to go forward with the procedure. And when it comes down to it, for you to learn the procedure is critical. For you to adapt it and start doing your practice is the only way we know if we've done a good job tonight. So if you do, then I did a great job. If you don't, then I guess Billy didn't do a very good job. So that's how I'd have to leave it. I don't know. Right. You tell me.
All right. Well, thanks for that. I appreciate that. I'll take that. So anyway, on behalf of Avanos Medical, I would like to thank you guys for coming tonight. If you have any additional questions, the information's right there on the screen. You can visit the website there, or call us, or reach out to your representative. So this concludes today's program, and we very much appreciate your time and attention, and you have a great evening.
Thank you, Avanos, for having me on. It was a pleasure.
Yeah, thank you, Dr. Stevens.
You're welcome.